Journal Club time, Renu.
Yay, it's that time again.
I really look forward to these journal
Yeah,
clubs
I'll
now.
learn a lot.
Yeah.
Dust off the old journals and pull out some great papers from the past.
And that's what we're
some
going to do
new
today.
ones. And that's what we're going to do today.
So welcome to GUcast Journal Club. This is our third Journal Club in our new monthly Journal Club series, supported by our great partners MSD, who are supporting the entire GUcast Journal Club effort. And welcome back to our two fantastic Journal Club editors here in the studio with us. We have Carlos Delgado. Carlos, welcome back.
Thank you.
I had to pull him out of a proprostectomy and said, come on, Carlos, it's Journal Club time.
Yeah, an hour ago, these two were doing a prostatectomy, and here they are now in the studio. And joining us from Munich, Elena Berg is back. Elena, welcome back.
Hi, Elena.
Thank you. Great to be back. Hi.
She's just finished Oktoberfest and looking pretty good, I must say.
Having more fun than us.
I mean, Oktoberfest is crazy, isn't it? It was all over TV here, every day, all these crazy things that happen. So it was one of those bucket list things. I never got to Oktoberfest, but am I too old now, Renu?
Probably.
You'll have to come eventually.
I'm kidding.
Now, speaking of too old, so Journal Club today, as we promised when we set out how we're going to do this, we picked two papers, or rather the Journal Club editors picked two papers in conjunction with myself and Renu. They may be two relatively recent practice-changing papers that are important for those of us working in GU oncology to know a bit about and critique and challenge like a classic Journal Club. Or we might pick a classic paper from the olden days. And so that's exactly what we've done today. Renu, we have the ERSPC paper from the New England Journal of Medicine 2009. That Carlos is going to cover, which, really was a seminal moment in the history of PSA testing, early detection and so on. I remember it very well because I am that old. Was it March 2009, Carlos?
That's correct.
I remember around the time of the EAU, it was March 2009. It read out at the EAU with the simultaneous publication in the New England Journal. And also in the same edition was the PLCO paper, the other big screening trial that was long awaited. So they were clumped together and published in this edition of the journal, and Carlos is going to run through that today. And then following that, we have the NIAGARA trial.
Brand new.
Yeah, pretty much brand new. So we haven't covered this in detail, but I remember we did speak to Jim Cato about it at ESMO last year.
Yes, when it
Madrid.
was in the presidential plenary.
After Tom read it out. And
that was a big deal.
NIAGARA, important paper, very important paper for anyone working in muscle-invasive bladder cancer. So that's coming up later on.
Yeah.
But yeah, Carlos, so ERSPC, how, you're too young to remember when this came out, unlike me, but it's an extremely important historic paper. And indeed, it has continued to produce papers over the years. So give us your quick summary, because it's definitely important for people out there to understand the context of where we are today with PSA testing.
That's right. First of all, it's a massive trial. And it's hard to summarize it quickly, but I'll try to do my best. Okay?
Good on you.
Okay.
The ERSPC is one of the most important trials ever published in urology. This landmark European PSA screening trial was published, as Declan said, in 2009 in New England Journal of Medicine at the very same time as the PLCO trial, generating, as you would expect, many controversies. In the early 1990s, there was a great excitement for this new prostate cancer biomarker, PSA. PSA testing was already widespread in the United States, but not very widely available in Europe. The ERSPC was launched to evaluate what would happen if organized PSA screening were actually introduced in a large unscreened population. Okay. There had been several updates of this study in 2012, 2014, 2019, the most recent. But I will focus more on the on the first one, 29.
Yeah.
Okay. The aim of this study was to evaluate whether if PSA-based screening actually reduced deaths from prostate cancer compared with no screening. It was a multi-center randomized controlled trial across 7 European countries. More than 182,000 men aged 50 to 74 years old. A screening arm, there were 2 arms, the control arm, which there was no organized screening, and the screening arm, which had a PSA every 4 years, 2 years in Sweden especially, And the biopsy threshold was 3 nanograms per milliliter. No control arm or just no systematic screening, and the primary endpoint was prostate cancer-specific mortality. The median follow-up at the time of the published, when it was published at the New England Journal of Medicine in 2009, it was 9 years. The latest analysis is from 16 years, published in European Urology in 2019. And key results of this trial were there was 71% increase in cancer detection for the intervention arm. There was a 20% relative reduction in mortality on the intervention arm. And this mortality risk reduction was only seen in the group of 55 to 69 years old group. The number needed to screen was to prevent one cancer death was 1,410 patients. And the number needed to diagnose to prevent one cancer death related to prostate cancer was 48 at that moment. Later, in the most updated follow-up in the 2019, this reduced to 18 men needed to diagnose to prevent one cancer death, and 570 men needed to screen to prevent one cancer death. The absolute mortality risk reduction per 1,000 men was 0.71. Later follow-up and after adjusting contamination of the arm, it was reduced. The mortality reduction was up to 30%. And well, there's big comparisons with the PLCO trial, which is the American study, which pretty much evaluated the same. But in this case, the most critique of the PLCO trial is that almost 50% of the men of the control arm were also received a PSA. So it was very hard to improve mortality if both of the arms were having a PSA. As a discussion, also ERSPC proved that organized PSA screening saved lives, but at a cost of overdiagnosis of 30 to 50%. Nearly double the number of cancers were detected in the screening arm. And this trial really triggered evolution toward smarter screening, MRI triage before biopsy, PSA density, risk calculators, genomics. And it was really a bridge between a screen everyone and a screen smartly. The strength of the trial is a massive sample. It's very well conducted. It was randomized, rigorous follow-up, centralized mortality review. 85% of the patients with biopsy recommendations were indeed biopsy, whereas in the PLCO trial, only 40% of the patients who had an indication of biopsy got really a biopsy, very low. The limitations of the trial were that there was a lot of heterogeneity among the different centers. There was limited, the point of the study, there was early follow-up, and also there was significant overtreatment. There was also a 20% contamination in the control arm in some parts in some centers of Europe. Up to 20% of contamination. And at the point of that study, they were done with sextant biopsies, which nowadays is not the standard. As take-home points, PSA screening reduces prostate cancer mortality by 20 to 30%, but causes considerable overdiagnosis. And really key message now is screen smarter, not more. And use modern tools, MRI, biomarkers, and risk-adapted follow-up.
Well done, Carlos. I think you did a good job, Renu.
Very good job. Yep, I like those comparisons to the PLCO trial. Same issue. Isn't that crazy?
So just for the context, I suppose, I remember I had not long finished my training when this trial came out in 2009, and it was highly anticipated. And it came out, and our initial reaction was, look at that reduction in mortality, 20% reduction. But very quickly, like within weeks and months, there was this massive backlash, massive. And remember at that time, kind of spontaneous use of PSA in communities around the world was increasing because there was a sense that mortality was decreasing. And then what happened after ERSPC 2009 is a bunch of bodies, in particular in the US, the US PSTF, the US Preventive Services Task Force, came out in 2012. So they'd had a look at it. And 3 years later, they issued this so-called D recommendation, extremely negative against do not offer PSA testing. And in the US, that really matters. And I remember here in Australia at the same time, the RACGP, the College of General Practitioners, similarly, in their kind of, they call it the Red Book. It's their preventative tool book they use for preventing all sorts of diseases. So screening falls into it. Extremely negative. Do not mention it. Do not bring it up, literally, it said. And it said, if you are going to mention it, make sure you mention all the harms, including, suicide even, and way beyond overdiagnosis, overtreatment. So it was an extremely disruptive few years, directly triggered by the moment that this paper got published. We'll come to PLCO in a second. And it reverberated all around the world with the USPSTF here in Australia, very negative. So the trend of increasing use of PSA, earlier detection of localized disease, mortality dropping, then began to reverse. And then from, around 2015, 16, 17-ish, you began to see that as predicted in data in the US in particular, that the progress that had been made for decreased mortality began to reverse. And ultimately, what it led to was the USPSTF changed their recommendation again from a D to a C, basically accepting it. And I suppose, why did they do that? Because the longer term follow-up of USPSTF did lead to, better gains, as you said. Instead of being number needed to screen, like 1,400 men have to be screened to save one life. And the number needed to be detected was like 48. And so there was, those numbers all improved and became pretty much like what breast screening is and so on. So that's kind of the tail of it. It was an incredibly impactful thing when it landed with a big thud, and then reverberated around the world for years and years, and undoubtedly led to, maybe it was needed. People will say maybe it was needed, that it stopped all this overdiagnosis and overtreatment because active surveillance hadn't arrived at that time. MRI testing hadn't arrived at that time. So my reflection on it now in 2025 is I'm probably a little bit more reflective of the critics, actually. I probably think, people probably were right to push back a bit, to say, do not do what they did in the ERSPC, because there will be too much overdiagnosis and too much overtreatment. So it's led to, in 2025, as you said, Carlos, maybe smarter, we don't even call it screening, we call it smarter early detection programs, informed things. But it's really been active surveillance, the recognition that even if you do diagnose these low-grade cancers, you're going to mitigate the overdiagnosis by not overtreating. And even then with MRI, what that means is if you do an MRI prior to a biopsy, you're going to cut out loads of the overdiagnosis because we'll miss all these low-grade cancers don't need to be seen. So so for me, I remember the era very, very well. And I think for listeners and viewers, that's why it's a pivotal trial. It was an incredibly important trial, as you said in your introduction, one of the most important trials ever produced in prostate cancer. So Renu, what do you think?
Yeah, it's crazy how much the pendulum has kind of swung in different directions. And, since this trial it swung towards this overdiagnosis, overtreatment, number needed to treat of 1,400 to save one life. I mean, that seems ridiculous. Even 48 to treat to save one life. But I think better adoption of active surveillance protocols and use of MRI, now routinely in Australia, not just doing these sextant biopsies as was done in the trial. I think all of these things have kind of brought a lot more balance into the equation. And now we are, like you say, we're detecting smarter.
Yeah. So we asked you to focus on PLCO, but you mentioned that there was another screening trial published at the same time, the PLCO, US-based trial, because it was prostate, lung, colorectal,
prostate, lung, colorectal, and ovarian.
Yeah, and the key criticism of that was all the contamination. So it ended up being a trial comparing screening with slightly less screening, and it was never going to show a difference. But it became And we all kind of pushed back against that, saying, come on, it was screening against a little bit less screening. We tried to push back against all those people. And it still is very limited, I believe, in that view. But I still accept that the overdiagnosis, overtreatment meant that it probably was appropriate not to sort of fall over and say, oh, yes, everyone should have a PSA test.
Only 40% of the patient who needed a biopsy in the PLCO trial actually got a biopsy.
I don't know why that is.
Because it was that the treatment decision was left to the community doctor. Yeah. Could be a urologist or could be a GP who was leading the.
Mm. So was the PLCO trial presented somewhere? That time
I can't remember. I mean, ERSPC was at the EAU. Yeah, when it came out. So PLCO, I don't remember being at the EAU. It probably came out at AUA or something soon after, because these were urology trials. You wouldn't see them at ASCO and places like that. But Elena, so is there awareness still in trainee groups now in Europe of ERSPC and the value of it? Is it something you come across?
Yeah, we do definitely. And I'm also happy that we've come this long way towards smart screening or smart detection of prostate cancer, which is what we have in our guidelines as well, and that you're having a look at not only the PSA itself but also all the surrogate parameters. But they're still present.
And ultimately, even that, I think nowadays, even that comment you just made is that the fundamentals are still based on PSA testing in this at-risk group of 50 to 69, the classic ERSPC thing. So it still has resonance. It's still the foundation strategy is the use of PSA testing, broadly speaking, in that age group of well men.
Yeah. I mean, a lot of people would argue it's still the best biomarker we have.
Yes.
In prostate cancer.
Just don't do like in ERSPC and use it on its own
judiciously. That's right.
I think that was a superb summary, Renu.
Yep, very nice. Thank you, Carlos.
Well done to Carlos. Thank you very much for that. Yeah. Now, Renu, bladder cancer time.
That's
Everybody loves bladder cancer, as we know.
So bladder cancer is interesting, and for those who do a lot of bladder cancer and do cystectomy, we know that neoadjuvant chemotherapy has been huge in the last few years. It leads to an improvement in survival, downstaging of the tumor at surgery, and so. Many centres have really adopted that, that all patients really who are coming up for a cystectomy should at least be considered for neoadjuvant chemotherapy. But, it's not without its problems. Neoadjuvant chemotherapy is toxic. These are not the fittest patients who have muscle-invasive bladder cancer. And there's an argument that giving chemotherapy can delay curative surgery. So, there's been a lot of controversy in this field. And to muddle things even further, we have the NIAGARA trial that looks at not just neoadjuvant, but peri-operative and a period of adjuvant durvalumab. So over to you, Elena, to discuss this important trial.
Yeah, so the NIAGARA trial was presented at ESMO 2024 and has been published in the New England Journal of Medicine in November last year. And as you say, the background of the trial was that we know that neoadjuvant chemotherapy prior to radical cystectomy improves overall survival and represents our current standard of care for cisplatin-eligible patients with muscle-invasive bladder cancer. However, recurrence rates remain really high, still with up to 50% after 3 years after cystectomy. And further, we have seen that in the past, adjuvant immune checkpoint inhibitor therapy can improve disease-free survival in patients with a high risk of recurrence. So the aim of the NIAGARA trial was to evaluate whether the addition of peri-operative immunotherapy to neoadjuvant chemotherapy may improve oncologic outcomes. So 1,063 patients were included, which were all cisplatin eligible and had muscle-invasive bladder cancer. They were randomized 1-to-1 to receive either 4 cycles of neoadjuvant chemotherapy with gemcitabine cisplatin in combination with neoadjuvant durvalumab, which is a PD-L1 inhibitor, prior to radical cystectomy, followed by adjuvant durvalumab for 8 cycles every 4 weeks, versus neoadjuvant chemotherapy and radical cystectomy alone. The primary endpoint was the event-free survival and the pathological complete response rate. defined as T0 and 0. And key secondary endpoints was the overall survival as well as safety, among some others. When we come to the results, a significantly improved event-free survival was seen at 24 months with 67.8% in the durvalumab group versus 59.8% in the comparison group, with a hazard ratio of 0.68. And this benefit was consistent across all subgroups. A 10% higher pathological complete response rate was seen in the durvalumab arm with 37% versus 27%. The overall survival was also significantly improved at 2 years with 82.2% in the durvalumab arm versus 75.2% in the comparison group, with a hazard ratio of 0.75. There was no delay to surgery between the groups, and it didn't have an impact on a patient's ability to undergo surgery. And concerning treatment safety, treatment-related adverse events occurred in a similar amount of patients. Grade 3 to 4 was about 41% in each group. The most common ones were nausea, anemia, constipation, fatigue, mostly things related to chemotherapy. And the treatment-related death occurred in 3 patients in each group. So in conclusion, in this trial, the peri-operative treatment with durvalumab in combination with neoadjuvant chemotherapy led to improved event-free survival and overall survival when compared just to neoadjuvant chemotherapy and radical cystectomy alone. The trial has several strengths and weaknesses. Strength are, of course, its large randomized phase 3 design. More than 1,000 patients were included in 22 countries. That it is the first peri-operative trial for muscle-invasive bladder cancer in this setting, and its results have directly influenced the evolving standard of care for that disease. It was shown that treatment intensification did not preclude patients from undergoing radical cystectomy, and that toxicity was manageable and broadly similar in both groups. Limitations include that the trial does not address questions about the optimal patient selection, health-related quality of life, and important economic questions like cost effectiveness, which may be challenging in various health systems. We don't know about the contributions of the neoadjuvant and the adjuvant component of the therapy. Do patients need either, or do they need both? Another limitation is that very few patients in the control arm had access to adjuvant immune checkpoint inhibitor therapy, which is the standard of care for selected patients nowadays, and that there might be potential biases from for endpoints like the overall survival from different post-protocol subsequent therapies in metastatic disease and access to those therapies.
Very nice.
Another
summary.
excellent summary.
Yes, yeah. This was a fantastic presentation by Tom at the presidential Tom Powell's at the presidential session at ESMO, and you know it's the first thing really since neoadjuvant chemotherapy that has shown to improve overall survival in medicine, in muscle-invasive bladder cancer. The absolute numbers are interesting, Elena. The overall survival numbers are 82% versus 78%. It's not a big difference, is it? And now you're talking about adding an extra agent in the neoadjuvant setting and in the adjuvant setting. I guess it really is going to be a toss-up between benefit versus toxicity and expense, although it seems to have been very well tolerated in the group. What are your thoughts?
Yeah, and I think one of the big questions to answer is, do patients really need both parts, or do patients maybe just need the neoadjuvant part or just the adjuvant part? That is one of the challenging questions here, but we'll get the answers, I think, in the next weeks and months when also the other peri-operative trials will come out and be presented at the conferences.
And the other interesting thing, of course, is the complete pathological response rates. You know, who's able to achieve T0 with the combination of neoadjuvant chemo and neoadjuvant durvalumab. That I think could be a really interesting thing to look at in the future as well. Who can potentially avoid surgery with this combination of systemic treatment?
Yeah, I heard someone last year at ESMO after this, and it's kind of in anticipation of other trials like EV303 is coming this month. Some cheeky oncologist said to a bunch of surgeons at ESMO last year, maybe we need to consider cystectomy to be like an adjuvant thing. You know, we'll have wiped out the cancer with these neoadjuvant / protocols. So maybe we need to do a trial of adjuvant cystectomy. So, but it's interesting because, of course, we discussed this when we had a really good, was it with Seema Porton, talking about trying to spare your bladder. And of course, patients are highly motivated, understandably, to not have a cystectomy. And that is a thing in some of these neoadjuvant intense immunotherapy studies is, if there's a complete response, at a pre-op cystoscopy, I don't want a cystectomy, doctor. Fair enough.
And I think, the challenge is going to be the uptake of this, because the uptake of neoadjuvant cystectomy is really not consistent across all centres. I mean, people are reluctant to give patients chemotherapy prior to surgery, despite the evidence showing that, there is survival benefit. So now this dual thing, and the adjuvant period of treatment is fine, but it's the neoadjuvant setting. I think that the uptake will be challenging. I think I just came across this great abstract. It's upcoming for ESMO Asia actually, and it's looking at predictors of who and seeing if we can better select patients who will really benefit from that neoadjuvant treatment rather than giving it to all comers with muscle-invasive disease who are going for radical cystectomy. And I won't give away the abstract because it'll be presented, but I think that's interesting work as well.
So that because in your opening, Renu, earlier you said, neoadjuvant chemo, it's been shown to have an overall survival benefit years and years ago, although that's still a modest benefit. But then now you've just said correctly that despite that, and it's in every guideline, I mean, the proportion of patients getting neoadjuvant chemo, even in cancer centres, is like, it's as low as 20%, 25, even in really, really enthusiastic cancer centres. I don't know, is anyone getting 50, 60%? I don't know. Elena, did you have any sense in Germany what the take-up rate is for neoadjuvant chemo?
Yeah, I think it's very different from center to center, but it's probably not much higher than those 20 to 30%. I mean, we also know that not every patient, of course, is cisplatin eligible. Just about like 50% of patients, but still, we could probably improve that still.
And that's a question to you then, and this came up in discussion last year because Jim Cato, a great urologist, mate of the podcast, was a participant in this trial, and we spoke with him afterwards on the podcast when we were at ESMO, and we challenged him. We said, "So, do you think will this make it any different? You've got this OS thing, and we're still waiting for regulatory approvals and reimbursement, but I don't know. Is there any reason to think, Elena, that this is going to be like 75%?" uptake in and now these were all cis eligible patients as well, I suppose, or will it be the same? Will it be urologists, especially urologists, will just go, no, I think I should just get on and do a cystectomy, and maybe it's partly what you said because they can have adjuvant nivolumab afterwards or whatever. I don't know. What's your feeling?
I think we're getting a bit better over the last month, and we will see very exciting results, as you say, EV303 and some other peri-operative trials coming up. So this whole treatment landscape is probably going to change a bit anyway. But what was also interesting is that the NIAGARA trial included patients that were not classically cisplatin eligible. They had a GFR of at least 40%, so kind of a bit more patients could be included in that protocol with this GemCis split dose then. I think we're getting a bit better in those rates.
Very good. So, bladder cancer patients are a different kettle of fish, really. I mean, these are patients often older, many more comorbidities. I think patient selection is quite important.
We're recording this podcast a week or so before ESMO, aren't we? So we've been hinting at that, but we probably won't post it till just after ESMO. So I'm conscious people listening to this might say, oh, what about that ESMO trial? So just in brief, what we're referring, I mean, there's 2 bladder cancer papers in ESMO Presidential this year, which is amazing. After NIAGARA last year was there. One of which is EV303. So that is the neoadjuvant EV Pembro study, and it's already been announced in a press release that it's met its OS thing. So it's going to be probably very similar looking to what you just presented, Elena. So again, it'll be on the topic of neoadjuvant, adjuvant approaches using immunotherapy or EV Pembro in this setting. And the other bladder cancer paper is that atezolizumab, but ctDNA driven adjuvant one. So it'll open up we shouldn't give it to everyone before and blindly afterwards. Why don't we do this ctDNA driven one? So it's exciting times because all of these are having significant benefits for patients, and hopefully we'll see them roll around. We probably need to do a dedicated episode in a few months on this landscape of neoadjuvant / peri-operative approaches. What's going to be the right thing in 2026.
Yeah, absolutely. Well done, Elena. Very nice summary.
Superb summary. I think, Renu, for people listening to this, trainees listen to this, be able to drop this into your conversations, at least in your MDT and your tumor board meetings, so you can show off to the bladder cancer experts in the audience who mightn't be quite across it. You don't
have to tell them you heard it at GUCast.
Yeah, you can say, but in Niagara, what about that? Pathological CR of 27% versus 37%, and have them look at you and say, "Oh, what's she been listening to?" So that's GUCast. We picked it up. And likewise for the ERSPC one, you can listen back and.
Wasn't that published in March 2009?
Yeah, wasn't that a seminal moment? I was riding my tricycle to school.
Tricycle to school.
You were, not me, obviously. I was still an old man by then. Great, cracking
Very
podcast.
Good, yes. What paper's next time?
I don't know. We'll have to put it on the WhatsApp.
Yeah, give us your suggestions.
Yeah, write into us. Yeah, please do tell us or get in touch with Elena Berg or Carlos Delgado and tell them what you want us to talk about next month. I think I really enjoyed the idea of a historic landmark paper, proper landmark paper from the history books of urology, and then a bang up to date high tech neoadjuvant paper.
And I love that we're not just doing prostate cancer. Good. Last time we did
wasn't that one of the rules?
Oh, was it?
You said we're not doing two prostate cancer papers in 1 month, Declan. Preferably none. Maybe we'll do that next month. We'll do a no prostate cancer. Hard to avoid. But look, thanks so much to Carlos and to Elena. Carlos, thanks very much for joining us again.
Thank you.
Thanks for having me here.
And to you, Elena, thanks very much for dialing in from Munich as ever again. And
thanks for having me.
Yeah, awesome. So Renu, that's it. We will be back next month again with another edition of GUCast Journal Club. Thanks very much again to MSD, our GUCast Journal Club partner, for helping us put this on. It's been a great episode.
It has. See you next time.